Bismillahirrahmanirrahim. Assalamu alaikum. The round of today is gynecological problems in obstetrics. Let's take this case. A 33-year-old woman complains of worsening abdominal pain for 4 days. So the complaint is abdominal pain. Duration for 4 days. She is 16 weeks pregnant in her third pregnancy. She has a 10-year-old son by normal delivery and had a miscarriage 8 years ago. So the obstetric formula will be gravid 3, para 1, abortion 1, delivered by normal delivery. Her pregnancy has been uneventful until now, with an unremarkable first trimester scan. So there is no problem until now. The pain is in the left lower abdomen, the side left lower abdomen, and is constant and sharp. Character of the pain is constant and sharp. She has taken paracetamol with little effect and she is unable to sleep due to the pain. All these criteria we take when we take history from the patient, the site of the pain, the character of the pain, if she take any medication to alleviate the pain. She has had no vaginal bleeding and report urinary frequency since the beginning of the pregnancy. She is mildly constipated and has no nausea and vomiting. This can be normal with pregnancy. There is no history of trauma. She has not felt the baby moving yet. This is also normal. Date of quickening can be 16 to 18 weeks. She is 16 weeks pregnant. By examination, the woman is abirexial. Pulse rate is 125 per minute with blood pressure 110/68 millimeter mercury with normal, but she is tachycardia. She has a tachycardia. Can be attributed to the severe pain she having. The uterus is palpable just above the umbilicus. This is a very important point in the examination. The fundal level. Normally we expect the fundal level to be below the umbilicus. It is 16-week pregnancy, but in this case it is above the umbilicus, so the fundal level is higher. This is significant tenderness over the left uterine fundal region, and we palpate the site of pain, which is the left side. The patient elicit tenderness over this region, and we feel a firm mass in the abdomen, otherwise soft, but other side of the abdomen is soft, non-tender. There is voluntary guarding but no rebound tenderness, because the rebound tenderness happen if there is peritonitis, like appendicitis, PID. Bowel sound are normal. Speculum examination show normal closed cervix and no blood. It's important to exclude abortion, accidental hemorrhage, and abruption placenta. The fetal heartbeat is heard and with handheld fetal Doppler. She had investigation, hemoglobin, platelets, reactive protein, all within normal. Questions: what is the likely diagnosis and how should it be confirmed? The diagnosis will be: there is a mass, tender mass, elevating the fundal level of the uterus. This mass can be a fibroid or ovarian cyst. The diagnosis can be confirmed using another investigation, which is ultrasound or MRI. Let's see this. Here is an ultrasound showing the fetal head on the left side and a mass on the right side. This mass is a fibroid showing red degeneration. So when a pregnant woman with a fibroid get pregnant, the fibroid can go through changes called red degeneration. As we know that in pregnancy, the hypercoagulable state can cause thrombosis in the blood vessels feeding the fibroid, adding to the increased size due to increased estrogen in pregnancy, which can cause increasing the size of the fibroid. This including the blood vessels to a largely growing fibroid can cause ischemia to the center of the fibroid and degeneration. This degeneration causes pain during pregnancy. This pain can be sharp, felt over the localized fibroid, and can be diagnosed by ultrasound. How would you manage this woman? The management of redegeneration of fibroid is mainly medical. You just give the patients supportive treatments until this thrombosis alleviate and blood supply continue to the fibroid. You give her fluid, analgesic, and antibiotic. Most cases resolve by this treatment, but small cases does not respond to this treatment and require surgery. The surgery will be removing the affected fibroid only. If the patient having multiple fibroids, we localize the affected fibroid. We can identify it by seeing momentary reaction over it and removing the affected fibroid only. What other effects can fibroid impose to pregnancy? It can cause recurrent abortion, especially if it is submucous fibroid, causing indentation in the endometrial cavity, interfering with implantation, can cause infertility, recurrent abortion. Pedunculated subserous fibroid, if it is large inside with a growing uterus, and the movement can cause twisting and torsion and abdominal pain. Here is an MRI picture showing the fetus and a mass beside it, which is the fibroid. Also, from the effect of fibroid on pregnancy, if it overcomes abortion, it can cause malpresentation, obstructed labor, preterm labor, placenta previa, accidental hemorrhage. Here is an ultrasound picture with another gynecological problem can happen with pregnancy. On the right side, we see a gestational sac and fetal pool, intrauterine gestational sac and fetal pool. On the left side, we see a mass filled with clear fluid. This is an ovarian cyst. This cyst can happen before pregnancy, or can happen during pregnancy, or during induction of ovulation, and a large cyst produced. The treatment of this condition will be during the second trimester, laparoscopic removal of the cyst if it produces complaint and complication like torsion. But during the first trimester, ovarian cyst can be the corpus luteum, and removal of the cyst can cause abortion. And in the third trimester, the removal of the cyst will be difficult. So the ideal time will be in the second trimester. Let's take another case. A woman present at 20 weeks gestation reporting vaginal bleeding. So the complaint is vaginal bleeding. The bleeding occurred at 2 hours ago was bright red. She reported no abdominal pain, so it is a painless bleeding. With the bleeding, and she had not had any previous episode. It's the first time. She had had intercourse the previous evening, so this can be an eliciting factor, an intercourse. Her last cervical smear was normal 2 years ago. This is her first pregnancy, and her current obstetric history is unremarkable with normal first trimester scan and Down syndrome screening. She reports that her booking blood test had been normal, so everything is with normal, unremarkable pregnancy. She is extremely anxious when seen, concerned that she is going to have a miscarriage. So the concern is having a miscarriage. Examination, blood pressure normal, pulse normal, abdominal examination confirms that the uterus reached 1 cm plus umbilicus within the normal site as it is 20 weeks. The uterus is soft, not tender, excluding the abortion. The fetal heart is hurt. Speculum examination reveal a reddened area around the external cervical os. This is very important. With an inflammatory appearance and a small amount of contact bleeding, the cervical os is closed. So, this patient having a contact bleeding due to an cervical erosion during the intercourse. This cervical erosion produce bleeding. This bleeding can be painless with no any uterine contraction, and cervical os will be closed. How to approach this case? This case is a bleeding during pregnancy. It can be due to gynecological causes like cervical erosion or cervical polyp. This can be confirmed by speculum examination, or it can be abortion with abdominal pain and open cervical os or close of cervical os, or ectopic pregnancy. But this case, excluding its abortion due to soft non-tender, heard fetal heart rate, and closed cervix. And we see that there is a reddened, eroded area of the cervix. So it can be cervical erosion producing contact bleeding.